Hey everyone, this is Frank. I'm going to start and go through hour 5 for our dry needling CEU didactic course. And this hour, we're going to go over a 2023 systematic review briefly, and then dive into some cases. So this systematic review looked at dry needling for myofascial pain with low back pain. So a couple learning objectives. Really, again, like I said, we're going to focus a lot on case studies to identify key muscles, recognize palpation landmarks, select appropriate needle trajectory, and then think about integrating dry needling into movement-based rehab. I'm going to leave this up for you guys. You can screenshot. I'm not going to talk through. This is a lot of what Dave and I have talked through in the last 4 lectures about some of the mechanisms and clinical relevance for physical therapy with dry needling. Here's another one again about the biomechanical factors, the neuromuscular features. Once more, a little review, screenshot, take a look, read through. Quick summary of the systematic review. So they looked from 2000 to 2023. They looked through comparing acupuncture, sham dry needling, PT, laser, neuroscience education. And what they found was that across the randomized controlled trials and meta-analyses, there was consistent short-term reduction in pain intensity. So dry needling can be used as a great tool to get some short-term pain reduction and enable people and patients to move with better control. There's improved pain-related disability scores. There's some benefits in both acute and chronic low back pain. And in general, the authors felt that it was likely a combination of the peripheral and central modulation, as well as improved muscle function. Long-term outcomes, evidence is limited and mixed. We see needling more as a tool to get quicker results. And as always, there's need for higher quality RCTs. This all aligns with some of the things we've gone over with local circulation, end plate activity, improved range of motion post, and less muscle stiffness. So I want to start to think about, before we dive into the cases, how do we decide when, where, and how to dry needle? Typically, I like to use 3 things. One is the irritability. Number 2 is the phenotype, the pain phenotype. And number 3 is the movement system to guide the treatment. So irritability really drives the dosage. You think about, sorry, here we go. When I think about dosage for dry needling, I think of a couple things. I think about depth and duration, how long the needle is in the body. I think about the intensity, so whether the stimulation or whether I go for a lot of pistoning, the technique with pistoning, the twisting with the dequai, and then also what follows treatment. In the high irritability category, you're going to see this high pain guarding. That's the acute protective phase. There's a lot of sensitivity to movement. There might be inflammation. It could just be a central nervous system guarding. For these patients, if I do dry needling, it's going to be much more superficial. It's going to be shorter duration, minimal pistoning, and avoiding aggressive twitch response pursuit. And then I'm really going to follow this with something that keeps the system safe. So gentle mobility, breathing. Again, this is not the time to be aggressive with needling. In the moderate irritability category, we can start to be a little bit more specific. The pain is a little bit more tolerable. It's localized. You can identify some trigger points much more clearly. So this is going to be your standard deep dry needling, a little bit longer duration. You're actually targeting those trigger points in muscles like the QL or the glutes or the multifidi. And this is where needling becomes that bridge into neuromuscular re-education. So you can do joint mobs, you can do re-ed exercises. In the low irritability category. These patients, they're your chronic, stiff, movement avoidant patients. You can start to get a little bit more aggressive with needling. You can pursue that twitch response. You can load them sooner, longer duration, deeper. You can, definitely do the stimulation. And this is where dry needling pairs really well with joint mobilizations and immediate movement. So immediate loading, thinking through Hodge's motor control principles, layering on top of the needling. The second thing I think about is the pain phenotype. This really matters. If this is primarily a nociceptive dominant presentation, it's going to have local pain, more mechanical behavior. They respond very well to dry needling. I've had the occasional patient who I do a session or two of needling, I do some motor retraining, and then they're good. Things clear up and they're good. In the nociplastic, this is where you see the hypersensitivity and that widespread pain. Dry needling alone is less effective, and as normal with the nociplastic or central sensitization, education, graded exposure, and reassurance is absolutely crucial. These two decisions here kind of helps you decide how much weight to put on the needle itself. I also want to think about addressing the drivers. So we'll talk a little bit later about what is driving the pain. It could be something like hip abductor weakness. It could be central sensitization. It could be a respiratory dysfunction. We're going to chat through with all these cases. What is the driver versus what is the compensation? So with that framework in mind, irritability, phenotype, and movement system, we're going to walk through a series of cases. And I want you to think through those same questions and the same things as we go. Safety. So we're going to chat through each of the muscles, the applied anatomy. So the neurovascular structures, especially between L1 and S1, organ proximity, the kidneys and the abdominal contents, and infection risk, as always. The higher risk areas are the deeper QL and the paraspinals if you do not have the bony backdrop. So again, just to drive this home, 3 questions before you need to: what system is failing, what is the driver versus the compensation, and what irritability level is this? So this next session, I'm going to go through several cases. Throughout this hour, you're going to see me kind of say pause and decide. Hit pause for a moment on the video. I really want you to think about this before it goes on. Think about it, all right, what muscle system is in play? Have you seen some patients like this? Okay, so case 1, we have, here we go. Case 1, we have a 38-year-old runner with unilateral low back pain for 3 weeks. Worse with contralateral side bending, some limited motion, stiffness with the first mile of running, which gets a little bit better with movement, and tenderness between the iliac crest and the 12th rib, maybe a little bit of pelvic drop gait. So pause for a minute and think about which system is contributing. All right, what we're really seeing here is a loss of frontal plane control. The QL can become a reactive stabilizer. So it's a common, the QL is a common contributor to asymmetric lumbar loading patterns. So yes, we can needle it, but we also have to ask about why it's working so hard. Oftentimes the muscle that hurts is not the one, or is often the one trying to save the system. So we think through anatomy. Safety considerations, we are going to have to be aware of the kidneys coming out underneath the ribs, the internal organs, and the subarachnoid spaces. Palpating the 12th rib, the iliac crest, and the transverse processes of the lumbar vertebrae. And then we're going to determine a lateral to medial approach for L4. I typically go for L4. Number 1, L5 is blocked by the iliac crest, and staying at L4, not going much higher, is going to help you stay well clear of the kidneys. With these patients, we often see lateral trunk stiffness, a pelvic height, issues with load transfer during gait, and obviously we're going to have to look at the contralateral hip abductors. So needling for the QL. Typically it's prone or side lying. I tend to like side lying. It's going to be a lateral to medial approach directed toward the lateral border of the transverse process. Again, I typically go for around L4. You can see right here. You're going to come in, go kind of through the obliques and into the QL. Clinically, think about the role of the QL in gait or altered gait mechanics. Oftentimes there might be some excess pelvic transverse plane rotation or later lumbar shifts, which changes the facilitation and inhibits the QL. Treatment sequence after needling. So, all right, we're going to do some dry needling to the QL to reduce tone and nociception. You could do this. I don't often do stim. You can use the point stim potentially, but I like to keep my hands on because of where things are a little bit more. But after needling, think about restoring that frontal plane control. So this is where we're going to go to the glute med loading. I'm going to default to weight bearing with this unless there's any contraindication to that. And then we're going to eventually reintroduce running load. Okay, case 2. This is a classic pattern. So we have a middle-aged male, 6 weeks ago, had a lifting injury and has had persistent lumbar localized pain. On exam, there is poor segmental control. He has tenderness of his paraspinals, and there's a palpable divot in the musculature as well. So pause for a moment and think through which muscle system may be contributing. All right. In this case, I tend to think about the multifidi being the key driver. So lumbar injury often leads to that multifidus shutdown or inactivation, and then the erector spinae take over. So now you have this persistent stiffness without local control. You have the global muscles working, but the local muscles not firing as well. And so here the needle can help, but the goal is to restore segmental stability. So the needle allows us to tap in through movement. Multifidus anatomy. So safety considerations, again, think about the kidneys, internal organs, and the subarachnoid spaces. Along that, the palpation of the paraspinal gutter will be lateral to the spinous process. If you push directly down, you can look for hypertonicity or a divot indicating some inhibition, some atrophy, or in some cases you can have fatty infiltration or in some fibrosis of the multifidi. This is a great transverse view here, which is very helpful for needling. So they tend to see that needling 2.5 centimeters or more lateral appears a little bit more risky due to the higher frequency of not contacting the bony backdrop. So what we're looking for here is we're really going to go for that bony backdrop. And we're going to have an inferior medial and a posterior anterior angle coming in this direction. So we're going for that bony backdrop. You're going to use a finger spread. So you typically one finger width away from the spinous process. We're going to angle the needle in 30 degrees to the paravertebral gutter. We're going to go A to P and a little bit inferior medial. Treatment progression for multifidus. And with all of these are all in isolation, but in clinical reality, you're going to needle several muscles. You're going to be doing several treatment retraining and movement retraining after this. This multifidus, in my experience, responds very well to stimulation. The big thing to hit afterwards is segmental control exercises. This might be something as simple with some true inhibition of hands and knees, lifting the knee 1 inch off the table and holding it there, and almost like a pre-bird dog stabilization to get some firing, progressing to a bird dog, progressing to a little bit more activation, a row with a bird dog, a single leg deadlift. And then we really want to get into that hinge pattern retraining. This is something that really helps fire the multifidi. So I'm going to make sure the patient knows how to hinge. It might be a bridge, it might be a kneeling hinge, or the right patient, it might be a standing deadlift motion. Then we're going to add some resistance to that to really be able to work on hypertrophy of the multifidi. I think as PTs, we do a great job of reactivating the multifidus, but we don't often progress to the hypertrophy that is needed in rehabbing the multifidi. Okay, case 3 is a desk worker, chronic thoracolumbar tightness. She's got rib stiffness, pain with rotation. On exam, we're going to see hypertonic paraspinals. And in this case, maybe think about the right mid ribs with decreased anterior movement. So she has trouble rotating to the left. So pause for a minute and think about which muscle system is contributing. So in this case, the erector spinae, they become dominant when that multifidus is inhibited or if trunk rotation is poorly controlled. These patients often feel tight, but the tightness is actually compensation. They tend to have this compressive spinal stiffness. And this happens when the erectors are doing the job that the stabilizers are not. It could be the multifidi, it could be the obliques, but there's going to be this excessive compensation. Anatomy, similar to multifidi, we're going to want to be aware of kidneys, internal organ puncture, and subarachnoid spaces. So for palpation, the muscular mass lateral to the multifidi, those fibers run from the sacrum up to the thoracic TPs and intercostals. Feel for any hypertonicity or hypertrophy. There may be an increase on right and left, and usually after multifidi inhibition following injury, you're going to see increased activation of the erector spinae. It could happen with scoliosis or any other kind of mechanical failed load transfer as well. A tight fascicle may create a rib rotation to the ipsilateral side. So in this case, the right side, there might be a tight fascicle, which is creating a rib rotation, which is then limiting contralateral rotation. So this patient, hey, I might try to mobilize the rib first. If they're too guarded, if the muscles are too hypertonic, I might do needling first, then come back and do a mob or a nip for the rib, and then follow it up with retraining. Approach for dry needling, again, it's going to be a posterior anterior directed at that gutter. You can also do a lateral, so the gutter here, oh, yep, there you go. Gutter is number 2, so coming down this way. You can also do a lateral to medial threading with the right patient and the right anatomy and the right body type as you kind of go lateral medially through the muscles toward the spinous process. Think about the relationships here with the ribs, that the inferior attachment implications, SI joint nutation, hypertonicity, what's happening at the SI joint when these are hyperactive, and typically you're going to see inconsistent recruitment patterns with low back pain. Clinically, after needling, it is important to restore thoracic rotation through that TL junction and above. And also going through breathing mechanics. The diaphragm attaches to the thoracic spine, TL junction, upper lumbar spine on the inside. And oftentimes we forget about this as a contributor to the muscular system. Okay, case 4. This is going to be a postpartum athlete. So she's complaining of trunk stiffness, some breathing dysfunction, and poor rotation. On exam, you're going to see a rib flare and poor abdominal activation. So pause for a moment and think through which muscle might be impacting. So internal, external obliques. This is where things get interesting because now we're talking through some rotation. The obliques are not just abdominal muscles, but they're also part of the system that transfers load between the thorax and pelvis. When that system fails, the lumbar spine often pays the price. So they show altered activation patterns, altered loading of the lumbar spine. Big safety considerations here are the abdominal contents. External obliques, we're going to palpate with, you can do some resisted contralateral rotation. If there's hypertonicity, that may restrict ipsilateral rotation. There might be a rib restriction or a rotation of a rib or thoracic segment with a hypertonic segment. Similar to the erector spinae, I always look at the internal and external obliques when someone has a rib or thoracic segment dysfunction. Internal oblique, we're going to palpate with the opposite. Ipsilateral rotation, hypertonicity of the internal oblique may restrict the contralateral rotation. Again, you may see rib restriction, thoracic segment issues. And there's going to be an influence here also with innominate rotation. These patterns have been shown to vary. So there can be overactivation with breathing patterns. Hey, again, the diaphragm might not be as active, and instead they're using their obliques a bit. Chest grippers or military posture, postpartum postures, and activation sequencing issues with the transverse abdominis. Needling for the internal and external oblique. We're going to be doing both at the same time. This is done in side lying to allow gravity to pull the abdominal contents away. You're going to take a pincher grip, and we'll go through this all of these in lab, but we'll take a pincher grip to hold and pull up the muscles between the fingers when you thread the needle, like so. Clinically, with integration for the oblique system, again, they have a key role in trunk rotation, rib mechanics, pelvic rotation, and then load transfer between the thorax and pelvis. Drivers of internal and external oblique issues could be breathing dysfunctions, over-reliance on the RA, postpartum abdominal changes, and excessive flexion training. Well, your patients who do tons and tons of sit-ups. Clinically, you're going to see that rib flare, poor rotational control, and you can test them in seated. You can do a resisted rotation in, neutral and flexion extension in C. So dry needling, we're going to be working to reduce hypertonic fascicles, decreasing any nociceptive input, and then restoring tissue extensibility. After needling, we really want to make sure we restore rotational motor control, breathing mechanics, pulling that diaphragm, and thorax and pelvis dissociation. So this might be something like half kneeling rotation drills, breathing with trunk rotation, and maybe some diagonal chop and lift patterns. We're going to talk about, since we're here, the rectus abdominis. So anatomy, safety-wise, again, the abdominal contents are big here. Palpation in supine, you can have them elevate their head and palpate the rectus abdominis. Insertion on the pubic tubercle up to the fifth to seventh ribs and the xiphoid process. There tends to be high activation when the other abdominal muscles are active, less so in side plank. Overactive RA can contribute to thoracic kyphosis, and an overactivation can impair oblique function. It can dominate flexion, limit rotation, and reduce that oblique contribution. So oftentimes with RA, the goal is not to strengthen it, it's actually getting it to do less so the rest of the system can work. Needling for the RA, I don't think I have a needle here, but identify the segment of interest. You're going to needle with an inferior angle. You can use a pincher grip, ideally, and a little bit of skin tension. You're going to avoid abdominal contents and not go very deep. Again, consider the patient body type and any subcutaneous tissue. Clinical integration for the rectus abdominis, again, is often overactive, not underactive. It's going to be associated again with the rib flare, flexion dominant strategies, and poor breathing patterns. After needling, or sometimes instead of dry needling, Do some breathing and some internal oblique and TA integration, and avoid reinforcing the flexion training bias. Okay, here's one of the most common patterns that you'll see. So 55-year-old pickleball athlete, lateral hip pain for a couple months, intermittent low back pain, difficulty walking, difficulty with stairs and single leg tasks. On exam, pelvic drop in stance, tender over the greater trochanter, and there's some increased lumbar paraspinal tone. So pause for a minute and think through which muscle system. All right, so this is the primary driver, the classic gluteal system issue. There's a movement system failure here. So with loss of frontal plane pelvic control, that pelvis drops. You're going to have less glute max drive for hip extension. Lumbar spine compensates, and the QL can even become overactive. Glute max, primary force production for extension. Glute med, deltoid of the hip, but frontal plane stability is a big one. Proprioception as well. And then the glute min is really a deep stabilizer, rotation control, femoral control muscle. The key here is that if the pelvis becomes stable again, if we can get the pelvis stable through the gluteal system, the lumbar spine often calms down and becomes quiet. Anatomy of the glute med. Big thing to watch out here for safety is any kind of neural pain with needling. Sciatic nerve is nearby. Palpation, you kind of break it into anterior, medial, and posterior divisions. And usually there's going to be some tenderness and trigger points along that superior third, along with some lumbar pain. Tendon irritation, you're going to see with some biomechanical faults. Bursitis often accompanies the tendinopathy. This is that kind of mixed patient of kind of gluteal tendinopathy, also greater trochanteric bursitis. Needling for the glute med. Think about side lying or prone. Palpate the margins of the muscle. Identify any irritable points, trigger points. And then you're going to needle toward the innominate with the superior portions. And the muscular tendinous portion, you can go down around the greater trochanter as well to get in there. This is showing you the superior portion going toward the innominate. You're going to obviously go through the glute max and potentially get down to the glute min as well, which is, if I draw that out, that's right there. Below that is glute min. Above this line is glute max. Clinical integration for glute med. Its role is the primary pelvic stabilizer during gait. It controls femoral adduction, assists in contralateral pelvic rotation. So loss of that control, again, can lead to increased QL tone, lumbar compensation, and lumbar compression via the excess extension and erector spinae overactivation. So we're going to do some dry needling to reduce trigger point activity, normalize the tone, and improve that recruitment potential. The big goal after needling with the glute med is to rebuild the stability and single leg control. So this might be lateral step downs, single leg RDLs, any kind of frontal plane loading drills. Again, weight bearing is much preferred here because of the higher activation. Glute min is going to be deep to the gluteus medius. It is a big stabilizer of the femur in mid to late stance. With the glute med, it helps rotation of the pelvis. You can have trigger points with some somatic referral as well. A study looked at a referral point in thermal imaging, saw increased short-term vasodilation in referral patterns for the glute med, kind of coming down the leg a bit, almost kind of mimicking a radicular referral. Common tears for glute med and min in middle-aged and late middle-aged patients. Great deal of greater trochanteric pain syndrome. Same needling approach, just deeper for the glute min as the glute med. Prone, that says supine. Prone or side lying. It's going to be deep to the glute med. they're going to have lateral hip pain, and it may mimic some referred radicular issues. Because the glute min is a large femoral control key piece in the stance phase. If impaired, this may be that femoral adduction, internal rotation, and lumbar compensation. The person who goes to stand on one leg and their hip dives into adduction and internal rotation, and the lumbar spine goes into excess extension or anterior pelvic tilt. After needling, think about step down with alignment cueing, single leg stance before a single leg squat. I would even do kind of some TA activation before you move on to that single leg stance to see if that improves. And anti-rotation drills, again, in weight bearing would be fantastic. You can start off 2 legs, go tandem or split stance, and then go to 1 leg. Glute max. Big considerations here are the sciatic nerve and the superior gluteal nerve irritation. Attachments along the iliac crest, down to the sacral ligament, into the femoral and IT band. You're going to see occasionally, butt grippers or military posture. Think through gluteal versus deeper rotator as well. We didn't talk about with this lecture, but the deep rotators, piriformis, gemelli, obturator internus, are all needling targets as well. Glute max, it's force production and protecting the spine during loading. When it's not coordinating well, the lumbar spine often takes on that role. Needling, sorry, again, it says supine. It's prone or sideline. Same direction as the glute med and min. Make sure you go medial and laterally away from the sciatic nerve. So think you can kind of come in like this. You can also come in this direction. Kind of stay clear of the sciatic nerve. Clinically, afterwards, after needling, it's big focus is to restore hip extension pattern and the posterior chain coordination. Hip hinging, bridge progressions for the right patients, deadlift patterns, and split squats. This is paired very nicely with the multifidi activation. That getting that whole posterior chain firing really well. Okay, so putting it all together, we have a patient with lateral hip pain. They have a pelvic drop, and they have some lumbar symptoms. So where do we go first? What do we do? How do we address this? One potential sequence. All right, with the pelvic drop, if the glute med is the primary driver, we needle the glute med and the glute min, the deep stabilizer. You can do with or without stimulation. If the QL is reactive, we can needle that. And then I usually needle the multifidi for that lumbar segmental control. We then follow that with movement retraining. And with all of this, I'm going to now address kind of all 3 of these issues. So we're going to do single leg control with some added pelvis or trunk rotation for multifidi control. So I might have them stand on 1 leg, cross the arms, do a little rotational hinge to get the multifidi segmental control improved. We're going to go through some gait patterns and then think about hinging as well. So to review, for lumbar spine, target selection framework with these muscular systems. First, I like to ID the movement system failure. So what is not being controlled? Is it a segmental control issue? Okay, maybe multifidus. Is it a frontal plane pelvis issue? Maybe the glute med of the QL, rotational control, load transfer extension being the glute max. After I figure out or think through the movement system failure, then I want to think about, okay, well, what's the primary driver? Because the reality is a lot of people have multiple things going on. So what's the primary driver? What's failing or compensating? Oftentimes, not always, but often, something that is weak or delayed or poorly coordinated might be the primary driver. And then something that is overactive and painful is more the compensation. So this is going to be the erector spinae when the weak multifidi are not firing correctly. Generally, as a framework, I'm going to make sure that I treat the driver, treat the compensation if needed to calm down the system, and then reinforce with movement. So heavy on motor control. And with the lumbar spine, I also almost always do some deep breathing, diaphragmatic breathing after or during needling as well. After motor control, I'm going to think through loading strategy, pattern retraining, and then really adding load and continuing to add load. So the big takeaway here, other than the muscles and the points that we'll go over in lab time, is oftentimes think about treating the driver, then the compensation, and then that allows you to get to the movement. All right. So Dave is going to pick up, I think, with hour 6. And like always, please let me know if you have any questions.